Hello and welcome again to another session of Voices of Healthcare Cloud. We are so excited that you have joined us today. We have some really amazing presenters and speakers on a great topic. But before we get started, we have a couple of housekeeping items. We do encourage our attendees to ask questions. So make sure you engage and ask with us. We do have the chat open now, so go ahead and give us a shout out of who you are, what country or city you're calling from, or what company you represent, anything you're willing to share. We'd love to engage with you and say hi. Questions will be moderated, so they won't show out to the general unless that moderator actually publishes it out, and we will do our best to answer everyone's questions that are either in the chat or we will ask our presenters to answer them live. The webcast will be recorded and posted back to our blog at aka.ms/HLSblog after the session. So now, how to engage with the Q&A. At the top right-hand corner, you'll see a little question box. If you click that, it will open up our Q&A panel where you can publish and ask your questions. So please start taking advantage of that and giving us a shout out of who and where you're calling from. So now enough of me, on to the presentation. Today we are being joined by Jared, CMIO from Nuance Communications. We are so happy to have him here, and a bunch of really amazing speakers from Intermountain Healthcare. Again, so thankful for their time and willingness to talk about optimizing documentation in the EHR with Ambient AI. Jared, so excited to have you. Welcome.
Thanks, Shelly. I'm really excited to be here, with my co-presenters. I'm going to go ahead and take over sharing my screen so I can present. And I apologize, I don't have two monitors today. I'm working somewhat remotely, so you're going to have to see our faces for a second before I switch over to our PowerPoint. All right, so hopefully you all see my PowerPoint slides now. So I'm going to just go ahead and jump right in. As you heard our titles. I'm an emergency medicine physician and have been working in kind of ambient speech capture and building that into AI for about 8 years now, and super passionate about how can we relieve the burden of documentation, administrative tasks of providers and help them actually focus on the things that they love to do and that we want them to do in taking great care of their patients. I'm excited to have Mike and Tyler here with me from Intermountain, as I know they are equally passionate about solving these problems. And so today we're going to talk a little bit about healthcare's current state in Ambient AI. And then I'm going to hand it over to Mike, who's going to take us through kind of the Intermountain and SCL coming together into one Intermountain, how SCL, part of Intermountain, was early adopters on one of the AI solutions, Dragon Ambient Experience. And then Tyler will talk more about how Intermountain Utah and Idaho has been working to build out real metrics around how this AI is useful, has been useful. So first off, I want to talk a little bit about Microsoft and Nuance. So I love talking with the Intermountain team, because you think of Intermountain and SCL coming together, two amazing organizations in healthcare coming together for something even better. And Microsoft and Nuance is exactly the same. I was lucky enough to be part of the Microsoft Nuance partnership for the last couple of years, where I was able to see how the Nuance leadership in healthcare AI, and really we were the inventors of the conversational AI space back in the late 90s, early 2000s, really front-end speech in healthcare. When people think of that, they think of Dragon, they think of PowerScribe, and Microsoft really digging in with us a few years ago and saying, hey, Nuance, we want to learn healthcare. And realizing after a couple of years that the synergy was so great that they decided to acquire Nuance, which is so exciting for me, because now I think of the scale of the impact that Nuance can make. And Nuance has been growing like crazy over the last couple of years. We're moving into international space, but when I think about the scale that we can have with Microsoft, it just kind of blows my mind. And so we really think of Microsoft and Nuance as so much better together because of the depth of the healthcare expertise and AI expertise around speech for Nuance, and then Microsoft's scale and growing AI expertise. There's only a few companies in the world with kind of the compute power of Microsoft, and now you team that up with the deep healthcare knowledge. I don't think there's any company in the world that can compete in healthcare tech like Microsoft and Nuance can. And I think that what that allows us to do is really solve the biggest, baddest problems in healthcare. And really, it's all to come down to amplifying the doctor-patient relationship. What we want to do is allow doctors to really connect with their patients, really show that compassion by, putting a hand on their shoulder while they talk to them, look them in the eyes, pay attention to the body language from the patient, and deliver great care. So I'm super excited to talk to you more about what we're doing today between Microsoft and Nuance. So real quick, I want to kind of define this space that we talk about, which is ambient clinical intelligence. Now, I was a medical director of an emergency department in a rural Virginia. And one of the cool things that I was able to see in that capacity was the cloud, the power of the cloud, where, before there were cloud tools like Dragon Medical One that were just not available for us in that rural hospital. We didn't have local big servers to implement things. And so it's really been cool to see how powerful the cloud is in extending technology through all areas, all geographies, and really the world. And ambient clinical intelligence is using the power of cloud compute to run AI models that just were not possible before, to be able to do machine learning in a rapid, iterative way that was not possible when you're talking about local installs that need to be updated. And it's really also leveraging the power of the Internet of Things. And today that could be your phone, your watch, your tablet, it could be other sensors picking up what is going on in your environment and helping with this clinical intelligence. What we're going to talk today is really a phone app-based application that allows for recording of the doctor-patient conversation, applying AI to it, delivering it back through the cloud, back into the EHR, and making it a seamless experience for the doctor and the patient. So I kind of set the stage. What is this ambient capture look like? And you're going to hear so much more from Mike, from Tyler, what this actually is like in a day-to-day practice type basis. And when we first started capturing ambient conversations between doctors and patients, we had all sorts of hypotheses, all sorts of worries. We were worried that patients wouldn't want to consent. And we've found that it's well over 90% of patients that are happy to have their conversation captured so that their doctors can focus on them. And so the technology is really about how can we push as much to a natural conversation between the doctor and patient, and maybe even ask the doctor sometimes to practice more active listening and really being more clear with their patients in delivering their plan and their medical decision making, and capturing that conversation that allows for the AI and right now a quality reviewer to complete that clinical note and push it to the finish line so that a provider can save lots and lots of time from documentation and instead spend that focus, spend that brain power, that cognitive load on taking care of their patients. So that really is what our solution today ambiently captures that natural conversation and works to complete a clinical note seamlessly for the provider and the patient. So with that, I've kind of set the stage. I'm going to bring Mike in to tell us about Intermountain and SCL.
Jared, if you want to move on to the next slide there, please. So yeah, I was starting, let's see, it was early April that we finalized the merger between SCL Health and what was legacy Intermountain Health. And it's been a really wonderful opportunity to bring two groups together that really had a very similar vision for what we wanted to do in the healthcare space, not just in our own areas, but really healthcare across the country. The concept being we really just want to help people to be the healthiest they can be and to retain some of the Catholicity of some of our care sites that we have here in legacy SCL. Go to the next slide, please. So the new Intermountain has a pretty broad geographic territory. In fact, one of the largest health systems in the country now. And that really allows us to have a great pool of resources to draw on. Actually, the next slide is probably the one I think is more relevant for this. And that is, we got a lot of sites, a lot of docs, including if you look at the bottom right-hand corner there, 3,800 employed providers. And that means there's a lot of people who we have to help out and try to maintain their well-being, as well as an opportunity to try out new things. Let's go to the next slide, please. I don't want to spend a whole lot of time on this one. Actually, we'll skip this one. And then it's this one I think is kind of critical. Now, a lot of this stuff is not unique to Intermountain. I think a lot of other health systems are looking to do similar things, expanding our digital engagement of patients, really empowering our providers, as well as, like I said, look out for their well-being, maximizing the return on investment that we get from the technology we've deployed, making sure that we're leveraging the technology to the best we can. And the last piece there, which I think is really important, is evolving and maturing the partnerships that we have in the industry. Next slide, please. I think the partnership piece is really critical because the old kind of traditional vendor customer model really is outdated. I think COVID really kind of shook things up a bit too, but really we're looking to have sort of that next level partnership. We're really working together with our vendors, in this case, Nuance, Microsoft, not only to share risk, but really to improve trust, to deepen the integration between the two of us. And we think that's the way that not only can we derive the most value, but it's an opportunity for us to help build great new things that are coming down the pipe. Next slide, please. And to that, we'll move in then to what our sort of early adoption experience was with DACs. When we were looking at this, at what was then SCL and is now Intermountain Peaks region, we were kind of thinking, what questions were we looking to solve? And I don't think these are unique to us either. We want to reduce physician burnout. We want to improve the quality time that providers have to spend with their patients, including improving the patient experience too, and empowering them more. And in the end, improving the healthcare of the communities that we serve. And I personally think that that last piece stems from the other three, because as we provide better experiences and can focus more of our efforts, kind of like Jared was saying earlier, on actually being doctors, then we are going to provide better healthcare. And really, it all boils down to that term in quotes or in italics, or the quality time, because that's really the piece that every doc I talk to misses. You know, I've never talked to a doc that says, you know what, I think documenting is a value-added experience in the patient experience, right? In the patient encounter. And so if we can ease that so they can really connect better to that human being sitting right in front of them, not only do we improve the quality of the experience, but we're improving the outlook of the physician as well. Let's go to the next slide. So Jared talked about this a little bit. Actually, I think we could probably skip this because you covered it beautifully, and go on to how we started off our pilot here. So we involved a few different specialties. We had some cardiologists, a few orthopedics specialists, a lot of primary care, and used DACs both in the sort of face-to-face in-person setting as well as over telehealth. We got about 16 total providers in our first cohort, added a bunch more in second. We continued to grow on that. But in the end of our pilot, we got about just a little under 5,500 total encounters and about 6,500 total notes completed. So a decent amount to kind of get a feel for what DACs was worth for us. Can you go to the next slide? So this is a little bit more detail on how the actual flow works. So the provider walks into the room, obtains verbal consent from the patient that it's okay, we record their dialogue, starts the recording, just talks to the patient. Doesn't have to necessarily frame the conversation in a particular way, just has a nice natural conversation with the person. does their exam, calls out findings, that sort of thing, discusses the plan of care, and then stops the recording. That goes up to the AI cloud. The AI engine generates a note. It's passed to a human being to do a little quality check on that, and then the note comes to the EHR for the provider to sign. What we used instead of a device specifically built for this was just an app on, in our case, an iPod Touch. And we used SCL owned devices so that providers didn't have to worry about their own tech support or anything like that. But it was really simple and it was unobtrusive. Patients didn't mind having this little device sitting on the table while they were talking to their provider. And the beauty of it is as long as the device could hear the conversation, you can use it in any setting. And I mentioned earlier, we tried this with telehealth, and as long as the telehealth audio was coming out of the computer and the thing could hear both the provider and who was connected remotely, it worked great, which means any telehealth platform you use is going to work well with this as long as the thing can hear it. Go to the next slide there. So this is sort of the summary of our findings from our initial pilot. And you can see some of the returns on this survey that we provided with the providers. But I think the piece that I really want to call out is that upper right-hand corner box there, the provider satisfaction. That 60% of the docs who used DAX would be either very disappointed or somewhat disappointed if it was no longer available. And in fact, I had docs that were telling me, please do not take this away. I don't know how I practiced without this before. And a couple of weeks ago, we got an email from one of them that said, this is the absolute best thing that I've ever seen. I'm going home tonight on time and I have no notes to write, which is something she's never had before. And that kind of impact really matters. Is it for everybody? Maybe not, but those providers for whom it helps, it is a game changer, an absolute game changer. And there's also improvements to patients' experience. I mean, that's not shocking, right? It's nice when the doc can actually look at you and talk to you as opposed to be nose buried in a screen, typing out away. And they also felt that the notes quality were improved and a subjective sense that time was being saved. And maybe, it's funny because looking back at that, it may not just be even time saved, but just more time more valuably used. Slide. This is just to give you some idea of the numbers of how we ramped up our use. Started off a little bit slow in May, but then picked up later on to get to that near 5,500 encounters that I mentioned. Next slide. And then a question that I often get when I talk to people about this is, well, what's the turnaround time like? Because again, there's that piece where human beings just reviewing what the AI generated to double check it. And in the beginning, it was a little bit long, but it really came down nicely. And towards the end of the pilot, the providers using it really felt like this was an extremely reasonable turnaround time, especially because it saved them so much time during the day or having to do these notes after hours. Okay, so that's kind of been our pilot experience. Now let's transfer over to Tyler, who's going to talk about more of the ongoing studies that we have planned for a wider scale rollout.
Yeah, thanks, Mike and Jared. And I'm Tyler Haberly. I'm a practicing internist in a small-ish retirement community in Southwest Utah. And so I want to just give you a little bit of information about what we're doing in the Utah and Idaho region to test out the DAX product and maybe go beyond perception data and get at some other measures of whether or not we're seeing value from this that can be a little bit more hard. And you can go on to the next slide there, Jared. And feel free to click through the next little doobly-doos there. So we have 1,000 providers, or excuse me, 100 providers in our pilot. I just gave myself a little bit of a heart attack. 100 providers right now in our pilot, and we've matched those to 100 providers who are not using DAX, and they're in the same specialty, and they have the same level of clinical volume and clinical care delivery so that we can make some powered decisions or interpretations of the data that we're getting from these two cohorts. And this is actually across 17 different specialties right now, but many are in primary care, and then we have a bulk in a variety of medical and surgical subspecialties. Our pilot is biased toward expensive use cases. We are trying to be hard on ourselves by is showing that if there is a financial ROI on this that we can actually execute on, it's because we were hard on ourselves financially with biasing towards more physicians than APPs and use cases that tend to be, there are less low-hanging financial fruits to execute on. And we're constraining ourselves right now in our pilot to do what will scale. So as an example, Nuance we're hopeful to use an API that will allow Nuance to directly push the documentation into our EHR. That doesn't exist yet, but when it does, it will come with a set of constraints. So we are piloting right now under those constraint assumptions so that if we rapidly scale, we're scaling what actually, we scaled what we piloted. We can translate the success from the pilot to a larger scale. I think we often make the mistake of piloting something with kid gloves and then scaling rapidly into an artificial circumstance. This constraining ourselves in the pilot reduces the flexibility and customization that is probably seen at most other clients, except where where Nuance and the EHR vendor may be leveraging an API for that documentation push. And we're also sort of limiting, like I alluded to earlier, the white glove approach that Intermountain in the Utah region is taking to human resourcing of training and co-support. We want to do this in a way that, again, rapidly scales. So throwing a lot of white glove support and training at it's not our modus operandi right now. And you can go on to the next slide, Jared. So here are a few. Now these are way too many measures of success, but what we're trying to do here is paint a broader picture than we would usually do for a pilot. And we are currently with 100 providers live right now on this. We're generating about 5,000 encounters per month. So we're generating a lot of data very quickly that we're going to be able to make some good conclusions around at the end of a 6-month period, especially as we compare those to our control cohort. But we're looking at measures of provider productivity in a fee-for-service model where they're generating work RVUs from direct billing of encounters. We're not incentivizing or disincentivizing providers to be or not be more productive with their time saved, but perception of time saved doesn't necessarily equate to increased quality, lower cost, or increased revenue. So we want to see if those things actually happen, and we're going to measure that in one of two ways. So the first way is that are providers actually seeing more patients? I know in my own clinic, I started cramming in more patients at the end of the day because I didn't have 2 hours worth of notes to do, but I'm not the same as every other provider in our pilot. We're also looking at physician engagement scores, provider engagement scores, and an assessment of our patients' likelihood to recommend our location, because we can somewhat indirectly tie those to the cost of provider attrition, the cost of recruiting new providers, the revenue lost to our market competitors with differences in likelihood to recommend for the clinics that have a heavy penetration of DAX use within them. We have a good portion of our primary care providers who also provide value-based care. They have a panel of attributed patients where we have negotiated at-risk contracts with payers to not operate in a fee-for-service model of more face-to-face visits equals more revenue. It's really about lowering costs and improving quality. So a direct measure of work RVUs or productivity of those providers doesn't make sense. They're not incentivized to see more. In fact, they're incentivized to not see who shows up in their clinic. They're incentivized to reach out to the people who are not being seen, who probably need to, and address some of their problems over the phone if that's appropriate, or make a house visit. So for those primary care providers where our value-based care strategy is highly, highly critical, we're actually not looking at these productivity measures that I mentioned earlier, but how many of attributed patients can they bring into their panel if there's truly some cognitive and cost and time savings happening from their documentation in that value-based care play. If you think about what we're doing here, we're also decoupling the provider and patient face-to-face interaction or telehealth interaction and the timeliness of their note and their charge submission with a turnaround time, because it goes to the cloud and then has a human reviewer. That turnaround time has the potential to introduce a risk where, because the workflow is now decoupled, right? I would say a good portion of providers complete their notes, complete their documentation and their CPT submissions within the same day that they're seeing patients, even if it takes them, hours and hours after work, because it's a part of their consistent workflow. We're now disrupting that. So are we introducing, in fact, a compliance risk for submitting charges when documentation hasn't been complete or doesn't ever get complete because of a mistake or another delay or extremely long turnaround times, et cetera? So we're monitoring those as potential areas of risk. Of course, we're also looking at decreased time in the EHR after hours and measuring Jared and Nuance very closely on their turnaround time, as well as the percent of our patients who are willing to consent. And again, being hard on ourselves here. And if I can take a moment to say, we've particularly looked at clinics that have a high percentage of intimate partner violence identification and other similarly sensitive conversations to see what the opt-out experience really looks like there. And so far, our opt-out rate is less than 0.1%. So we'll continue to monitor that. But this, plus the subjective information that we're going to get from our providers with their perceptions, are going to tell the story for us about whether or not rapid scaling and just success in general with ambient listening and artificial intelligence to help our documentation actually is juice that's worth the squeeze. And again, what's next? Data, and more data, refining what we're currently piloting, and then scaling it. So.
Tyler, thank you so much for giving that overview. We do have a couple of questions. The first one, and I'm not sure who needs to answer this, if it's Michael or Jared or Tyler, or maybe a combination, but a question was around kind of what was the level of effort, I think people and technology, before you were able to really kick off a pilot and get that kind of technology integration started?
Yeah, it was, I think, fairly reasonable. And actually, to be frank, I was really impressed with how responsive Nuance was about these sort of things. There were a few pieces that were a little harder than others, as far as like trying to get folks the right access, whatever, just because that's some of our internal processes that were built around a different model. But actually, from a technical standpoint, it really wasn't too bad at all. And from like an operational people standpoint, it was really, in the early pilot, I think the biggest thing was just trying to identify who we were going to provide the service to. And now that we have some better ideas on that, I think that would be easier still. I don't know, Tyler, if you want to, what your guys' experience was.
Yeah, the technical lift is very, for an organization our size and with our, with our in-house skill set, very, very minor. And we intentionally kind of just, to our providers, we're very random with who we chose. And we said, look, you're going to get kind of a half an hour intro, half an hour of training, and then there's your app, go download it and let's see what happens. And so far that's worked out okay, but more to come in 6 months.
Awesome. So another question kind of around the same topic was, it looks like we have people that are considering doing something like this in the chat, but haven't really pulled the trigger yet. And so just wondering if there are any kind of big things that you learned that you can share as best practices or kind of gotchas that other people can consider as they can, start moving into a pilot like this.
I don't know if there are any gotchas per se. I think the big thing to keep in mind is that this is like any other documentation tool. Not everybody is going to get the same value out of it. Just like there's some people that really love using voice recognition and others that insist on typing and using, like discrete documentation, that sort of thing. I think when sort of coupled with the trying to identify providers that are particularly struggling with getting their documentation done, I think it's really critical to make sure that they give things a chance, meaning it's a new kind of way of doing things. And so it may feel awkward the first couple times you do it, but the more the doctors that really got into it, the more they used it, the more they loved it.
Awesome. So there is now on a different lens, it looks like Sherry from the audience, thank you, Sherry, posted, what about the patient side? How was the experience received by the patient? And were there any privacy concerns from their side with having to consent to or having listening devices in the conversation?
Michael, you have more outcome data than I do. I mean, all I can say right now is we've pushed really hard, and maybe that question came in before my comment about our intimate partner violence clinics and things like that. We've pushed really hard to be hard on ourselves, and so far, patients are telling us that, if this helps my doctor pay attention to me and not the computer, I'm all for it. So very, very low rates of patients declining to have their conversation recorded.
I'm not even aware of any in our situation where someone said no. Is the same thing. I think that the idea is that, oh, well, you can turn away from the computer for a few minutes and actually talk to me. Yeah, do it. I did think it helped when we said by using an organization-owned device. I don't know, because I think, Tyler, you guys are using a BYOD. I don't remember off the top of my head, but
yeah, we have providers bring their own device. They're using their own iPhone, and hasn't been a point of issue. So
that's great. Yeah, our original concern was that people were going to freak out. Oh, it's your own phone. Why are you recording it? But that might have been a concern that's not going to bear out with the data at all.
Yeah, I was just going to add that. I mean, I think Sherry asked if it was privacy concern, security concern, and I mean, for sure, it is a concern. But I think the really great thing about Nuance now, Nuance and Microsoft, is I can't think of more trusted kind of healthcare or tech companies around security and the amount invested in keeping data secure in the cloud. And the whole process, when it's recording on the device, it's always encrypted. If you were to lose your device, you can't listen to the audio. It's all encrypted on the device. It streams up to the cloud. The only way to listen to that audio again is to stream it back and listen to it streaming. So super secure. And so yeah, and then along with what they said, the consent level is almost a non-issue. It's always a concern when we talk to new clients. They wonder how many are actually going to consent, but almost 100%.
Can I share a little bit more about the patient experience? There's, I think, one thing to consider if you're implementing this, and I'm curious if Michael would agree or not. There is a culture shift that the technology introduces, whether you're ready for it or not. And it's a culture shift of the provider moving away from the computer and interfacing with the patient. And there are real pros and cons to that. A lot of the decision support tools that tend to drive best practices have operated under the assumption that my face is stuck into a computer. There's also the positive effect on the patient's experience through a culture change with the providers through this. So the providers quickly learn that the patient's story is very well captured in their note, and the part that's not is their physical exam and their assessment and plan. And the training, the feedback is, well, you need to tell your patient what you're seeing on your physical exam and be a bit more explicit about the problems you're seeing and the plan you're seeing. And it's almost like the light starts to go on for a bunch of providers. And this is all anecdote so far, right? But it's like, Oh, I need to talk more to my patient about what I'm seeing and what the plan is? Yeah, be more explicit about that. Oh, okay, that'll end up in my note better. So you have, and that's been positively reflected in the comments that we're getting from patients about how much more clear their care plan is when they're with a provider who's using DAX. But you have to anticipate that, and you have to anticipate that you're going to have providers who resist that because it's not the culture that they're used to, and there's a bit of paternalism that this technology undoes.
It's funny. I like to think of this as it helps you do things like you were taught in med school that you should be doing, right? Like you should be having a natural conversation instead of directly going to yes/no questions because you're banging down a template, or you should be telling patients what is going on in the exam while you're doing it. But I also think that to get at sort of how to change the culture of the computer in the room is that I think this actually helps enhance the ability to use it as a tool with the patient, because then you can like show them things and share what's going on there instead of worrying about getting everything in your note.
Yeah, actually talk to them like a human instead of talk to the computer and have it spit out a report or something. So enhancing the clinical side experience from documentation, but also the patient side, because you're talking to a real life human instead of looking at the back of their head while they're typing on a screen.
Well, I mean, one of the most frustrating things for patients is when a doc asks a question, they answer it, and then 2 minutes later, the doc asks the exact same question because they're too busy typing something else in and they totally missed it, right? When you're more active in the conversation this way and something else is taking care of the documentation, that sort of thing doesn't happen as much.
Awesome. Yeah, thanks for that. Hey, go, Vasu.
I was going to say, Shelly, we have a question about the AI engine that runs behind the scenes. Is it specific to a specialty? Are there efficacy rates for different specialties? Can you guys peel back the layers a little bit on that?
Yeah, that's a great question. So currently our AI has been trained on over 5 million of these pairs of real patient recordings and finalized documentation. And the reason that's really important to just point out that it's real patient conversation is because people ask all the time, like, well, how does it know what to put in my note? Well, it knows because it's listened to 5 million of these patient encounters where the patient goes off and talks about elk hunting or, ATV riding or visiting New York City and seeing a Broadway play. Like it's heard all of that and knows that that's not the medically relevant information, so it leaves it out. And so overall, this you can think of this AI tool that's been trained on all this natural conversation, and it knows medically relevant, not medically relevant. And then there is a tuning layer on top of that for each specialty. So there is a specialty specific tuning for cardiology that knows cardiac data better and is going to better know how to do an electrophysiologist exam versus an interventionalist exam versus a pediatric cardiologist exam. And it's gonna know all of that, and then it's actually tuned down to the provider level, meaning that provider can also give DAX their templates and call out, like this is a pretty normal physical exam. And if you've trained the model to notice that pretty normal physical exam means use my normal adult exam template, it will pull it in and it'll edit that. And so there's these levels. Now, accuracy is really difficult to measure in this kind of natural language generation AI. Because what is the gold standard? The gold standard is what the doctor would write. But what we've learned is a doctor might be happy to accept something that they didn't write that looks very different from what they may have written. And so defining like what is accurate is somewhat difficult. Now we do that with different measurements on how much the note changes from the AI production to the finalized note, how many characters change, clinical fact recognition, the number of clinical facts in each one. So we have all these measurements, and it really depends on multiple factors on where you end up on that accuracy layer. And I know that the question was peel back the layers. Obviously, I could peel back layers for the next hour, but I'll pause right there.
I think the question was from Brian, and he's most curious about oncology.
Yes, and we do. Yeah, we have oncology. Oncology is a really interesting one because one of the hard problems to solve in oncology follow-up visits are not very difficult for DACs to work in. Oncology new patient visits, where I'm bringing records from 3 other doctors and trying to get DACs to pick that up, that is much more difficult. And so then it becomes this kind of interplay between AI process and what the doctor does. And so I'll just say that there is some nuance in making those work better or worse. I don't know if Mike or Tyler, if you could speak to oncology and what you've heard from oncology partners.
I mean, yeah, we have some oncologists in our pilot right now, and what we quickly discovered was that it, especially for those new patients and even for return patients, where there is a great deal of summarizing previous clinical content that needs to be contextualized at each follow-up visit. But it's a combination of changing the workflow to have the provider interact directly with DACs, in addition to the conversation with the patients, as well as some EMR tools that will capture that narrative historical information that continue to pull forward. So it's a good combination of all 3.
Thank you, team. We have a bunch of questions coming in. We have a comment and a question from Sherry. Sherry saying that they currently use Dragon embedded within Athena and the providers love it. So that's excellent, Sherry. Thank you for sharing. And she's also saying that the training of the application was very minimal. What is the training curve for the AI for each provider?
Meaning like actually training the AI to understand them?
I think so. We'll wait for a clarification from Sherry, but I think that's where she's headed.
I think that was probably Jared. You're probably the best one to answer that.
Yeah, I'd say again, since this is a kind of breaking technology, we're on the bleeding edge of innovation for this technology. It continues to change what that means. But I'll just say kind of the provider training. The provider training is around teaching consistency. And as Tyler alluded to, teaching consistency of how I talk to my patients. So if I explain the physical exam well, if I explain the assessment plan well, then everything is going to be there to train that model and to train it even faster. On day 1, the physician is working with some AI tools, mostly diarized speech recognition. So separating out the different speakers in the room talking. It takes several, anywhere from tens to hundreds of patient-doctor encounters that are manually built into notes to then train the first natural language generation models for that provider. But like I said, it's a moving target. We're getting to a point where we're going to be just taking old notes from that provider, and on day 1, they're going to be starting with an AI model with natural language generation for that provider. Now, I do want to point out, we have this quality review step that means there's a person in the loop. And so you can think of this, we're following a very similar playbook to what we did with front-end speech, where you used to pick up your phone, dictate something, and then the next day you'd get your note back that would go through a transcriptionist. And eventually we built speech recognition that was good enough that it would speed up the transcriptionist, but you would never want to show it to the doctor because it would slow the doctor down for sure. But now Dragon Medical 1 is, Dragon Medical 1 measurements is actually better than transcriptionist. So it has a lower error rate than a transcriptionist. So going ahead and speaking into your computer is more accurate than using the old telephone to do a transcriptionist workflow. So we're following a similar playbook in that, we start with this review in the middle where a human is taking that natural language generation AI note, correcting it, and now we're working towards how do we get to that point where we can hand it directly to a provider. And in some cases with providers where we have lots of data, we are actually testing that in the field today. But like I said, it's still something that we continue to define.
Thank you, Jared. And thank you for sharing, a more extended and elaborate view to this whole situation. There's a question which is slightly more technical, which is, did you use Microsoft's cognitive services to understand the conversation, or did you train your own NLP algorithm?
Yeah, so this is Nuance's NLP. It's our speech recognition as well. And Microsoft's cognitive services, amazing. And it's really now this great opportunity where Nuance and Microsoft are working together to make Microsoft's cognitive services better and Nuance's AI better. And I think people will see that over the next while as they see cognitive services on Azure get smarter and smarter, especially in the medical realm. And as they see Nuance AI increase in velocity because of the amazing AI resources from the Microsoft realm.
Thank you, Jared. We do have some more comments in chat, primarily around the process. If the doctor can review the notes real time, or the timing of when they get access to the review. Does the manual review happen? How many days does it take? Can you just maybe shed some more light on that?
Yeah, so it started off where it was 4 or 5 hours as a turnaround time, but very rapidly dropped to about 2 hours on an average turnaround time for us between when the recording was finished to when a note arrived in the provider's in-basket to review. So definitely not on the order of days, but not real time either. That's kind of the goal at some point, but the same thing as front-end speech, right? We didn't have front-end speech real time right off the bat either.
Yep. Thank you. I think that's pretty much all the questions we have. Perhaps the one thing that's coming up in chat is the idea of templates and training. And I don't know if there's more that you all can add on that topic in this forum. How do you scale beyond, the pilot groups, perhaps? If you can touch on those topics.
Yeah, and I think that there's some interesting differences behind how we did the initial pilot and the way that the next phase is going to be going. I mean, we kind of let people use their own templates as they wanted, and I think that's part of what added a little bit more to the onboarding time as far as a people perspective, not a technical perspective. But I think, Tyler, you guys are doing it a little differently, right?
Yeah, we're more constrained, and so I think what we'll discover is where we've constrained some flexibility that we know we would have at large scale, we'll be able to identify who benefits the most from this type of technology, target those groups, and then we should be able to rapidly scale. Honestly, the part about scaling that concerns me the most is whether Nuance will have enough humans to do that human editing and keep the turnaround time at a reasonable time. So I think that's a good position to be in for scaling.
Thank you, team. I have one more question. Many of our listeners are bold clinical innovators, and they would love your perspective on how do you frame a business case? What are some calculations that you should be doing ahead of time in order to justify a project which is more forward-looking, essentially the future of telehealth, for example. Can you shed some light on those business drivers and how do you articulate those in order to establish a formal project?
It's a really good question. I mean, I think part of the thing is that there's some of these soft metrics, like what, how patients generally view this, how docs generally view this. I do think that given the burnout scenario that we have right now in healthcare, having to replace one physician would outweigh the cost of, most pilots for this, right? Even fairly large pilots. And when you see metrics like, 60% of docs basically saying, please don't take this away from me because it's made my life that much better. I think that's really how you make it. How you say, well, if we invest X number of dollars, we'll get Y number of dollars back. That I don't think we can say yet, though I hope Tyler's data maybe shows some of that. I don't know if, Jared, you guys have some of those numbers, but But I look at it from the standpoint of, you got a lot of providers out there who are kind of at the end of their rope. And if you can give them something like this that makes their lives better, you're less likely to lose them.
Yeah, I mean, I would agree with that and say, you know, if you're making a business case around technology like this in healthcare, I would suggest my humble opinion that your business case focuses either on burnout, which is a prima facie problem in healthcare. Burnout of physicians, APPs, nurses. That's, you know, turnover, burnout is just rampant. So there's that use case. I think there's a use case that you can make a pretty reasonable business use case around consumerism. So focusing on use cases that that play to that, and possibly, you know, revenue gains by increasing market penetration of healthcare services in a given region because they like your clinic more because the providers are just more engaged. I think that's a little trickier to do. And then the third one, which I think really aligns where U.S. healthcare is headed to right now, is value-based care opportunities. I would not put a lot of effort in trying to justify use cases that show like a revenue churn, like we're going to execute on a financial ROI of saving an hour of doctor's time to make them see an hour's worth more of patients, but more how can we steer care teams, right? So maybe this is not something that just providers will use in the future. I'm hopeful that we'll have pharmacists, nurses, medical assistants, clinical psychologists, social workers, and others also using this technology to reduce the cognitive demands that they have, the administrative demands that they have, so they can take on larger and more difficult care delivery problems, like ensuring transitions of care from the hospital to subacute care locations happens in a way that is safe and cost effective. So value-based care use cases, I think, is a really strong one you can make. Well,
I think at some point this is going to become a marketing thing, both from a recruitment of physicians standpoint, like you have the advanced tools to make it easier to document, but also, I mean, I could envision at some point someone's going to have a billboard that says, "Come to XYZ clinic," because your doctor will actually listen to you, you know.
Wow.
and
for sure. Whether or not it even proves a financial ROI, you're going to have a hard time recruiting. There will be organizations that have ambient AI assisted documentation and those that don't, and those that don't are going to have a harder time recruiting physicians for sure.
What a tremendous, point of view that both of you have shared. Thank you. Actually, this has inspired another question in chat. Who's your business decision maker for this? So, the question in chat is, who's providing this software? The doctor or practice is buying this, or the healthcare payers, or who is the use case, pitched to? If you guys can shed some light on that.
For us, it was, actually don't know how the initial conversation started, but it was basically a kind of a joint effort between medical leadership and IT, and everything was paid for by the medical group. It's one of the things that we're thinking about going forward is kind of how we expand it in an intelligent way, but also potentially having a way that says, if there's extra people who want to do it, that we're not ready necessarily to buy more licenses for, is that an opportunity for them to pay for it themselves. But we haven't run into that just yet.
Yeah, it's a strategic capital investment right now from our integrated delivery network.
Yeah, thank you. This question about building a coalition and consensus-based decision making comes up all the time. I would request any of our listeners to just reach out to the team and ask for any more detailed questions or discovery sessions. I know we're almost at time, so I want to turn it back to Shelley to close the session out and thank the panelists one more time.
Yeah, absolutely. Michael and Tyler, thank you so much. We love hearing customers' perspectives and real world scenarios. And Jared, again, for you joining us today. We are super excited about the potential of the future this has in healthcare. And, I definitely know people want to go to a place where their doctor actually looks at them and listens to them. So that should that should be normal, not the outlier. So hopefully we can get there. With that, I do want to talk about, we have a session, I want to say it's in 3 weeks on May 11th, where we have another AI partner of Microsoft that has built some AI models and is actually starting a pilot with regards to predicting and reducing collapse in the hospital space. And so we're really excited and hope that you guys will come and listen to our speakers from Synaptic in a few weeks, and how customers our health providers are taking advantage of these machine learning models. And that will be a wrap for us today. We will post the recording from today's session, and get the invites and LinkedIn posts out for our session that's coming up on May 11th. Appreciate you all and hope to see you on our next session.